Today we'll start the session with Dr. Muralidhar Oration, Role of Surgery in Stroke by Dr. Radha Krishna sir. And I invite Dr. Sita Jayalakshmi madam and Dr. Lakshman Rao sir. And I invite Dr. Sita Jayalakshmi madam to introduce the speaker.
ఫస్ట్ జూమ్ లో ఉండండి నా మాట
జూమ్ లోనే వచ్చింది.
Thank you, Rajesh. I, along with my co-chairperson, have the pleasure to chair this Muralidhar Rao oration. First, talking about Muralidhar Rao Memorial Oration, he is a great surgeon. I was a resident, and I had the opportunity and fortunate to have seen him when he was in Gandhi Medical College. He was born in 1945, and he had a very premature demise in 1996. This oration was instituted in the year 1996 following the untimely demise of Dr. Muralidhar Rao, who is son of Dr. Dayanand Rao, one of the 5 father-son neurosurgeon combinations. And Muralidhar Rao was the student of Usmania Medical College for MBBS, and then he did his MS General Surgery, MS Neurology. He's trained under one of our teachers of teachers, Dr. Bal Parameshwar Rao, and later worked with Dr. Raja Reddy. And Dr. Muralidhar Rao, he headed the Department of Neurosurgery in Warangal and then in Gandhi Medical College, and is one of those instrumental in starting the APNSCA. Apart from neurosurgery, he is a keen artist, sportsman, and endeared himself with students at college sports and cultural events. And he organized the second APNSCA moot in 1995, which all of us attended as residents in Gandhi Medical College. Now it's my pleasure to introduce my teacher and one of the finest teachers, Dr. H. Radha Krishna, who is going to deliver the prestigious Muralidhar Rao oration. Dr. Radha Krishna sir is a senior consultant neurologist at Care Hospitals, Nampalli, after his retirement from 2013 from Usmania Medical College. He is a clinical director, neurologist of Care Hospitals from 2019. And he is training the DNB neurology candidates at Care Hospitals, Nampalli, which is very popular. And he did MBBS from in 1978, and he passed out with first class in SV University. And then he did MD, DM neurology. Can you hear me?
Yes, madam.
Yes, sir. Then he did his MD General Medicine in April, and he was one of the toppers of the university, and in DM Neurology from NIMS Hyderabad, where he was my teacher and a senior resident, and I learned a lot. And he is a great teacher with a vast teaching experience. He was assistant professor at Kurnool Medical College, followed by Guntur Medical College. Then he worked in Usmania Medical College as associate professor, followed by professor. And his lectures are vastly attended, and they are very popular, both at Usmania Medical College and then Care Hospital. And presently, a lot of DNB residents attend his classes from Telangana and Andhra Pradesh. He was the examiner for DM neurology students at NTR University of Health Sciences, MGR Medical University, KLE University, Belgaum. And he is also MCI inspector at Jawaharlal Medical College, Belgaum, and also other government medical colleges from various states and many corporate hospitals. And also he is member of government specialist team for recognizing the brain death certification as a part of cadaver organ transplantation. And to his credit, he is awarded Best Doctor given by Superintendent Government General Hospital Kurnool in 1998 at a very early stage of his career. And he has more than 16 publications in indexed journals. And it's my pleasure to welcome Dr. Radha Krishna sir to deliver this prestigious Muralidhar Rao oration. Over to Radha Krishna sir. Sir, can you hear us, Radha Krishna sir? Here, you have to unmute, sir. You are muted.
Are you able to hear me now?
Yes.
ఇక్కడండి.
Are you able to see the slides?
Not yet.
Start video చేయండి. Start video.
You're using the
Okay.
green button, share screen.
Yeah. This is the Dr. Muralidhar Oration medallion presented by Dr. The AP Neuroscientist Association.
Are you able to see?
Are you able to hear now?
See
Sita?
the slides.
We can't see the slides, sir. We can hear you.
Start video అంటే చేయలేదు. You can't. మీరే
ఇది.
మూలాలు మర్చిపోవద్దు మన దేవుడిని పట్టించుకుంటే
మళ్ళీ కొంచెం పోవాలి.
చెప్తున్నాను మీరు. స్టార్ట్ వీడియో చేయండి. ఇక్కడ స్టార్ట్ వీడియో.
Start పెట్టే ముందు
అవును మన
అది
iCloud drive.
presentations.
Muralidhar.
Are you able to see now? Hello?
No, sir.
Sir, have you minimized first the presentation?
Sir, maybe you have to start video, sir. Your
Sir, you
video is off.
start the you put your video on, sir. You have to
Video.
minimize the presentation. After that only, you have to share screen.
The presentation.
Switch on the video button, sir.
ఆల్రెడీ బట్
Already is switched on.
మీరు అందుకే ఫస్ట్ చెప్తాను.
But we can't see. Okay. But we are not able to see your video also. Yes, sir.
Yes,
Now we
sir.
can see the video.
Stop.
The first minimize the PPT, then share it, sir.
Minimize.
Minimize so that it is down in the scroll bar. Then you press share screen, then you will see it. Then you
How do you-
double click that.
How do you minimize?
Sir, press escape first. Then your zoom will become minimized. It won't go, but it will be there. Escape button.
షేర్ స్క్రీన్ చేయండి.
The PowerPoint you can minimize, no, sir. First.
This is not PowerPoint. This is iCloud Drive.
అదే iCloud drive అని పవర్ పాయింట్ కదా.
Even whatever is the presentation, minimize it, sir.
కనికిలే
ఇది ఇంకా ఈ మూడు చూడండి. ఈ ఇది
60-70 ఆయన ఏం చెబుతాడు
వాళ్ళకే ఉండేది వాళ్ళకి షార్ట్ టర్మ్ మెమరీ ఉంటుంది.
Okay, may I request others to this Yasin Pro? Can you please mute your thing? Lot of noise is coming.
డైలీ మనం అంతా పెట్టుకున్నట్టు
Even Penchalaya, can you please mute your screen?
షేర్దే ఇది. కాదండి అది కాదు. ఇది కాదు నేను అనేది.
Yeah, presentation is here.
Are you able to see the presentation?
Are you able to see? Sita?
No, sir. We can see only your screen, which is not even your face.
This presentation.
Presentation is here only. I know how to minimize this. We'll go back once again.
So what is the size of the presentation?
It is open. 54 slides are there. I think I already sent the slides to you.
No, I didn't get any slides, sir. Actually, I just got your CV.
No, not that. They are conference. Switch camera, Google Drive.
Sir, can you send to my mail? I'll just do it fast.
One second.
మెయిల్ పంపించమని.
కష్టం అయిపోయింది ఇదంతా మొత్తం.
లేదు ఉంది, వాళ్ళు ఇట్లనే చెప్పచ్చు మనం. అది కదా ఇట్లే చెప్పచ్చు.
Add to home screen, huh?
ఆహా కాదండి, మీరు షేర్ చేయండి.
Wait.
మీరు ఇది పడుతున్నారు.
Sir, could you minimize the PPT in the down?
Minimize అనేది
No,
ఎక్కడ?
I'm not
No
able to see
option.
that minimize option is
No,
not
option
there.
is not there.
The minimize will be in the PPT only, no? In the PPT, once you open your PPT on the desktop,
Share
instead
screen
of closing, can you minimize? Instead of closing.
షేర్ స్క్రీన్. ఇప్పుడు షేర్ స్క్రీన్ కానీ షేర్ స్క్రీన్.
చేయండి, otherwise do share screening, you will see your computer at least.
Yeah, we are sharing the screen.
And
Okay, do it.
iCloud Drive.
iCloud Drive. iCloud Drive, you are going back to that.
No, just go to your system, sir. Your computer screen unte danni share cheyandi first.
Computer.
దీంట్లోనే మనం పంపించచ్చు వాళ్ళకు.
దీంట్లో రాదు.
Sir, మీ మెయిల్ ఆల్రెడీ ఉంటే నాకు పంపించండి సార్. I will
already it is there. I will send it to you.
sita.js.
దాన్ని ఆన్ చేయండి. ఆన్ చేస్తే
నాకు ఫార్వర్డ్ చేయండి.
అదే అండి, అదే వచ్చేసి ఫార్వర్డ్ అంటారు కొట్టండి.
SITA
dot JS, J for Japan, S for Singapore.
సీతా జయలక్ష్మి
at gmail.com.
At Gmail.
ఇది ఇంకో మెయిల్ సార్, జీమెయిల్ కి అయితే బాగా వస్తుంది. SITA.J for Japan, S for Singapore at gmail.com.
Okay, I have sent now.
I'm just checking, sir.
వచ్చింది వెళ్ళిపోయింది.
Got it?
Not yet, sir. I'm refreshing it.
Madam, we have sent, madam.
Which mail? You have sent me the Radha Krishna sir's CV.
Yes, madam. That now same mail, madam. Whatever the sir has sent to us, we have
Okay.
forwarded.
Now I have sent a slightly revised version.
It doesn't matter. I got one. I'm projecting that.
Yeah, okay, please.
వచ్చింది మామూలుగా.
Sir, file name is Muralidhar Oration.
Yes.
Just give me one.
Muralidhar Oration.
Muralidhar Oration, yes, sir.
Yes.
కొన్నిసార్లు టెక్నికల్ అందుకే
Yes.
Yes, sir, you can start. I will scroll whenever you say next. I'll do it.
Can I scroll from my side? No,
sir, you can't do it because it's me.
So thank you very much, Dr. Sita, for all the kind words you have said, and also for the nice introduction. So I was fortunate to have interacted with Dr. Muralidhar in the initial few years, I think 94, 95, and it's a privilege to be honored with delivering the lecture on the occasion of this oration. So thank you, the organizers, Dr. Raju and Dr. Ravi et al. Next slide, please. I was asked to talk on role of surgery in stroke. Actually, I initially asked Dr. Raju whether surgery, is it really meant surgery only? Because I being a neurologist, so he said, no, sir, surgery only. Then I thought I added a word saying neurologist perspective. So from my point of view, what surgery means to us and what are the conditions where we take this. So the scope of the topic is life-saving surgical techniques are part of the stroke management in neuro-intensive care units. So all of us must have seen surgery being done for acute strokes. So different types of strokes. I think as time goes on, we'll come to that. Well, some techniques are only life-saving, some procedures curative too, like evacuation, cerebral or hematoma. There are many preventive strategies also that are medical, but some which are surgical, like carotid endarterectomy. I think I will add a few lines on the endarterectomy also in the last few slides. Thank you. Next, please. So my lecture goes through these 4 headings: decompressive craniectomy for ischemic stroke, and before hemorrhagic stroke surgery, concept of ICH expansion. This is also gaining importance, and a lot of importance is being given to the expansion of the intracerebral hematoma volume. So, and lastly will be carotid endarterectomy and my experience. So these things are not included in the lecture. Endovascular procedures by neurointerventional radiologists, aneurysms and AVM surgeries, and procedures for venous stroke. These are not included. So this is the first part of my lecture. So next, please. So decompressive heavy craniectomy for ischemic stroke. Most often it is done for the malignant MCA infarction. Life-threatening space-occupying mass effect due to the rapidly expanding infarcted tissue results in transtentorial or transforaminal, in case of cerebral infarct, herniation resulting in various complications, including death, and different types of ACA involvement, BCA involvement. You can see there will be subfalcine herniation, which may be associated with ACA compression and ACA infarct. So ultimately leading to mistaken impression that it is a total IC occlusion. Requires prompt evaluation and management to prevent worsening of the edema and further deterioration in the situation, ultimately resulting in death. Next, please. 1 to 10% of supratentorial ischemic strokes are due to subtotal or complete MC occlusion, M1 or M2 segment. These are the large vessel occlusions. The subgroup which doesn't usually respond to thrombolytic therapy, often associated with ACR, PC occlusion. There will be a massive brain swelling, and nearly 80% of such patients die in the next 7 to 10 days, and the remaining are left with, earlier slide, please. And this is what is called malignant MCA infarct. So whoever is remaining, they will have significant disability. Next, please. So you can see the malignant MCA infarction leading to going on to develop subfalcine herniation in the first slide, in the first picture. And in the second one, there is also PCA infarct as a result of transtentorial herniation. Next, please. So these are the cases which are very, very malignant, which are likely to increase further. The caregivers may be satisfied with a severe disability of MRS4 or even more severe disability of MRS5, where the patient is bedridden, incontinent, and tube feeding, while a survey of normal people suggests that they would not wish to survive with this disability. For example, if you contact a normal person, they will not like to survive with a severe disability. Next, please. There are some earlier studies which are in 2005 to 2010 and 2010 to later part. So the decimal studies, these are the landmark studies. The decimal study is decompressive craniectomy malignant MC infarction 2007, which was a French trial of 38 patients. Up to 55 years they have taken, wherein more than 50% of MC territory was involved, and NH score is more than 16. Surgery done within 36 hours after onset, mortality reduced from 76 to 25%. So significant reduction in mortality, but at the end of 1 year, there is no significant recovery. The MRS score is about 4 to 5. And Destiny trial also in 2007 is a German trial of 32 patients with more than 50% MC territory affected, NH score more than 18. Mortality reduced from 82 to 47%, significant improvement in mortality, but no statistically significant recovery at 1 year. More than 50% patients were in the MRS 4 or 5. So for your recapitulation, I bring the MRS. Next, please. This is the modified Rankin scale. Just to recapitulate, the 4 and 5 and 3 and 2, what I was referring to, 2 is a slight disability, 3 is moderate disability. We would like the patients to be in the 2 or 1 group, but most of the doctors, and in such severe cases, that your moderate disability is still acceptable, but severe and most severe, some attendants are happy even with most severe disability. One may also notice that the MRS does not include cognition and communication skills. Next, please. So these are the other 2 trials. One is in 2009. This is their extended time interval is there. Up to 96 hours they were taken for surgery. NS score more than 16, and 18 to 60 years. This is the slightly extended age group. And mortality reduced from 59 to 22%. Again, the result was not significant. Patient had MRS 4 or 5 at the end of 1 year. And the last one is Destiny, which is above 60 years. This is published in 2014. It's a German trial of 112 patients, where patients were taken from 61 to 82 years with a median age of 72 years, operated within 48 hours. Mortality came down from 76% to 43%. At the end of 1 year, only 10%, less than 10% patients had MRS of 3 or less, and severe depression was also present in all the survivors. Next, please. So once you look at the image and what are the predictors of expanding the infarct and leading to herniation and further problems, CT defect of more than 50% of MCA territory and perfusion defect of more than 66% of MCA territory within 6 hours of onset can predict the development of life-threatening edema with a positive predictive value of 86, nearly 90%. Additional SCA and PCA territory infarct has got another more predictive value. Diffusion MRI lesion volumes also have been measured, which are as taken as predictors. More than 145 ml and ADC map volume of more than 82 ml has high predictive value for worsening. So the larger the infarct, more amount of volume, more likely it is to expand further, and more likely it is can give rise to the herniation and further problems. The value of MR perfusion imaging is controversial, though it can also guide us in identifying patients likely to develop severe brain edema and herniation. See, these are the imaging predictors. We'll talk about clinical predictors later on. Next, please. Imaging can supplement other clinical predictors like hyperglycemia, more than 200, 250, 300, more than 400, definitely all of you know, is a contraindication for thrombolytic therapy also. Heart failure, leukocytosis, and in heart failure, actually the BP will be low, leading to further problems. In prediction of worsening, these are all other clinical predictors. And there are some predictors, intracranial total ICA occlusion, it has got a very low predictive value. Though most of us have seen that an ICA totally absent can give rise to increase in the size and can give rise to problems, but that is not it's got a very low predictive value. Similarly, clinical stroke severity itself at onset has low predictive value, because on day 1 there may be 0 power, and day 2 you give a bolus of fluids 500 ml, then suddenly the power may improve. Next, please. So these things have very not a good predictors. So what are the current indications for surgery? So day in and day out we are doing decompression surgeries for such patients. And remember, most of our patients are above 60, 65 years, but still we are operating. But the best is age between 18 to 60 years. And severe MCS syndrome, giving rise to dense hemiplegia, head and eye deviation, and global aphasia and dominant hemisphere involvement. And NA score is 15 in non-dominant hemisphere infarction and more than 20 in dominant hemisphere infarct. And lower level of consciousness, less than 13 and low. Deterioration of consciousness within 48 hours, it is likely further, but not taken up to 96 hours. And then CT and diffusion MRI, more than 2/3 of MCA territory with possible additional AC or PC infarct, diffusion MRI lesion volume more than 145 ml. Next, please. So these are the surgical modalities that are available. External decompression, that is you take out the hemicranial bone flap. Internal decompression is take out the infarcted tissue also. Bilateral hemicraniectomy. And total calvariectomy has also been performed in 1973. The entire calvarium is taken out. An optimum bone flap should include parts of frontal, parietal, and temporal squama and should not be less than 10 to 12 centimeters across. Inadequate craniotomy can result in parenchymal hemorrhage with or without infarction and increased mortality. So this issue, I have been quarreling with my surgical colleagues for a long time. They do, I think it's not adequate. They feel it is adequate, but the patient still deteriorates because of this problem. Inadequate craniectomy resulting in parenchymal hemorrhage and infarction. Next, please. So now, how good are these studies, and should we go ahead with these surgical techniques? So the comment at present there can be improvement in the further improvement in surgical techniques can be there, better care, surgical care. 1 year follow-up is too short. All the studies we have seen that at the end of 1 year, the MRS is only 4 or 5. And MRS may further improve with time, so that a final word cannot be said at this point of time. Patient suitability for surgery may improve with further studies and should not be operated more than 60 years old. But our patients are all above 60 years, so what should we do? So that I think we'll talk later. Surgery is better early in the clinical course, 48 hours versus 96 hours. But what to do later on in the course? That is also, yesterday we had seen a patient where after 10 days, the patient has got significant subfalls and herniation. There's a definite improvement in mortality in all the trials. So definitely there is a role for surgery, but how far is it good? At least some patients are in MRS less than 3 or less. So that's also another good point. So these are the controversies. Assessment of functional outcome. Is MRS good enough? Should we go for other Glasgow outcome scale or Barthel index? No, there are other indicators of functional. Some consider, as I told you just now, MRS 2 or MRS 3 are good. But for caretaker's point of view, MRS 4 is acceptable. Some also accept 5. What to do with patients older than 60 years? There is a significant improvement in mortality. Severe disability is seen in more than 32%. Later infections are more common. So more than 60 years patients are also acceptable for surgery, but we have to explain about all these other later complications. What about dominant hemisphere infarction? There's no indication in the studies dominant hemisphere infarction patients do not benefit. They also benefit. There is some language improvement with time. So they have to be operated and given the benefit of whatever medical care that we are taking. Besides, non-dominant hemisphere infarction may also be associated with neglect and attention deficit. So it's not that only non-dominant infarction is the only one which is not has got its own drawbacks. And timing of hemicranectomy, less than 48 hours or beyond. Best is less than 48 hours. So later on is it optional. Next. So these are our views from so much of experience of the surgery. And cerebellar infarction, particularly pica territory, are multiple arterial territories rather than anterior inferior cerebellar artery or superior cerebellar artery. Gives rise to space occupying edema. They can be obstructive hydrocephalus, compression of midbrain and pons, which may start as sixth nerve palsy, facial palsy, or later Harman syndrome. Upward herniation, that is the one which gives rise to this, and downward herniation, that is transtentorial, transforaminal herniation. Later coma ensues, followed by respiratory distress. Next. So these are the transtentorial, this is only for recapitulation, transtentorial ascending herniation from the cerebellum upwards, involving PCA and superior cerebellar artery compression. And tonsillar, that is downward herniation, giving rise to pica compression and other brainstem cerebellar compression. Next, please. So you can see that pica territory is close to the midline and is more likely to compress the midline structures when compared to anterior inferior cerebellar artery or superior cerebellar arteries. So this is more likely to give rise to pica territory infarct is more likely to expand further and give rise to more amount of infarcted tissue. Next, please. So the procedures that are available for surgical techniques, for surgery, external EVD placement, endoscopic third ventricular ostomy, suboccipital decompressive surgery of the posterior fossa, with or without removing the necrotic tissue, that is strokeectomy, with or without duroplasty. So this choice of these, we leave it to surgeons to decide. All of them, they have got their own protagonists and antagonists. So I think the third one probably is the better one, best of the lot. There may be additional brainstem infarction also in addition to the cerebellar infarction. So the surgery is indicated only when the deterioration is secondary to mass effect of the infarcted tissue rather than due to brainstem infarction. The time point at which to take up surgery is also not very clear. Radiological signs may be detected a little late. So clinical always is more dependable. Next, please. Surgery is associated with higher survival rates in cerebellar infarction. Definitely, it is one of the very good procedures for cerebellar infarction, being a very tight compartment. Survival rate of nearly 70 to 80%. Nearly 50% patients achieve MRS 0 or 1. Unfavorable long-term outcome may be due to age and associated brainstem infarction. The two retrospective studies have shown after studies up to 4 years, only 60% survival, and probably because of the age and also the brainstem infarction and associated later. And the falls, they still continue to have attacks and fall and sustain injuries. Next, please. See, I'll talk about I6 expansion. This is a few slides on this. Next, please. The intracerebral hematoma expansion, just like an infarcted tissue expands, hematoma also expands. So what are the predictors? And there was a lot of literature recently on this topic. Hematoma expansion is defined as increase in the size of hematoma from the baseline scan seen in a subsequent scan. Absolute increase by more than 12.5 ml in more than 24 hours. And relative increase by 33% in the subsequent scan as defined by Blot. For every 10% increase in hematoma size, there is 5% increase in the hazard of death. So about 10 ml, but mostly we take about 15 to 20 ml. An increase in the hematoma size is expected in other medical conditions, anticoagulant use, increased serum creatinine, and severe hyperglycemia. Next, please. These are the clinical indicators, and there are the predictors of hematoma expansion. The radiology are different. There are 4 phases in the evolution of intracerebral hematoma. First one is the vessel rupture. Just like Charcot, Bouchet aneurysms, they form and rupture, amyloid vessel, they rupture. And then baseline hematoma formation. This may happen only for about 1 or 2 hours initially, but later on the expansion occurs. So what are the factors which are responsible and what are the predictors? So hematoma expansion is the 3rd phase, and 4th phase is a very hematoma edema formation. This may start anywhere from 3 to 4 days after the hematoma formation and may go on for 10 days or 12 days. Predictors of hematoma expansion are large volume, more than 10 ml are more likely to expand. Irregular shape and irregular margins hematoma is likely to expand. These are the radiological predictors. Barra's grading of the hematoma shape grades 1 to 5. 5 is the more big volume hematoma along with small satellite hematomas. And there are some radiological signs which I think nowadays everybody is familiar. Swirl sign, black hole sign, island sign, and satellite sign. I think I'll show one or two. Next, please. This is the bilateral swirl sign. You can see bilaterally there is hematoma, and the arrow is pointing to, in the first slide, the arrow is on the left side, the second side arrow is on the right side, showing swirl sign in both the sides, and the expansion is a increase in the size of the blade. Next, please. Swell sign is also described in extradural hematomas, not only in parenchymal. This is the extradural hematoma showing swell sign, suggesting that there is increase. Swell sign is just like, you put some clothes in a washing machine, or how it is revolving, you can see that. So that kind of a sign you can see. Next, please. This is a black hole sign. You can see onto your left, you can see the black hole within the hematoma. And the same thing is also expanding the other slide, giving more explanation. So there are 3 black holes on this. And next, please. This is the island sign. You can see 1, 2, 3, 4, or 4 or 5 islands. You can see this is island sign. So that indicates the peripheral vessels also are slowly giving way and giving rise to hematoma. And if there's a single that satellite is called satellite sign. Next, please. So these are all the predictors, imaging predictors of hematoma expansion. Some more are contrast predictor, the spots sign. Extravasation during the CT angiogram, giving rise to hyperdense spots, particularly the venous phase. Most of us, we don't do CT angiogram in a hematoma patients unless you suspect some aneurysm or AV malformation. So if you do, you can see the hyperdense spot sign, which suggests that there is likely to expand. And maximal attenuation of hematoma, more than 180 Hounsfield units, is also another indicator that it can likely to expand. So after hemorrhagic expansion, we'll look at the hemorrhagic stroke surgery. So next please. Hemorrhagic stroke surgery is more dangerous and has got a more sinister history. Nearly 50% of intracerebral hematoma patients die within the first 24 hours after onset. And some of them may die before coming to the hospital. Nearly 30% require mechanical ventilation, and less than 20% are functionally independent at 6 months. The small volume hematomas may just separate the white fibers, and then after recovery, the patient will come back to normalcy. But larger size, more than 10 ml or 15 ml, as I told you earlier, they are likely to be left with significant deficits. So these are the landmark trials, Stitch trial, Stitch 1 and Stitch 2. Stitch 1 is 2005 and Stitch 2 is 2013. Surgical trial in intracerebral hemorrhage. About 500 patients in each group operated and considered treated. At 6 months, both had 20 to 25% favorable outcome, and both MRS score and also in Barthel index. More superficial hematomas, those without intraventricular extension, those operated within 8 hours of the ictus, and those patients with GCS 9 to 12 had better outcome. So these are the findings of Stitch 1 trial, which are almost same replicated in Stitch 2 as well. Next, please. This in 2013, 600 patients, 300 in each arm of early surgery and early conservative treatment, cross-total surgery when necessary. They were followed for 6 months. Here, the follow-up is only 6 months, short duration. Maybe there will be slight improvement after later. The result was same as the Stitch 1 trial. The early surgery of superficial lower hematomas with GCS between 9 to 12 has a better outcome. So both trials are almost similar. Next, please. This is the recent February 2019 trial, which was published, and minimally invasive surgery with thrombolysis in intracerebral hematoma evacuation trial. So injecting TPA into the hematoma under the stereotactic guidance and aspiration to reduce hematoma volume to less than 15 ml, 250 patients in each group. And this is MISTI 3 trial. There are other trials also. This study shows this trial gave 1 milligram alteplase every 8 hours, was injected for 8 doses, and later on it was aspirated. The procedure was safe, but again, no significant improvement is noted in large conservatively treated patients. And recently, I think last year, we had one surgeon from Mumbai who has talked on this topic, and he said they is routinely doing this procedure, but how far it's effective, even he was not very confident on the outcome. The procedure is being done, is very safe. Next, please. I don't know whether anybody is doing in Hyderabad. I don't think anybody is doing this kind of mystery procedure. Current role of surgery in hemorrhagic stroke. Surgery offers little benefit to older patients, those with less than 8 GCS and routine big ganglionic, basal ganglion hematomas. It's not useful when eloquent cortex is involved. Very much useful in cerebellar hematoma and lobar hematomas. I had the occasion to follow one patient for nearly 7-8 years when eloquent cortex was involved, and it's a really burden on the family and finances and also the social life. Next, please. This is the CLEAR 3 trial between 2009 to 2015. The amount of intraventricular blood, time for it to clear, and the development of hydrocephalus are independent factors of morbidity and mortality. So the removal of the blood is necessary. The intraventricular blood volume. There's a staging for IVH also, 1, 2, 3, 4, 5. Removal of intraventricular blood by saline irrigation versus thrombolytic drugs. So this is the CLEAR 3 trial. Use of streptokinase and urokinase is replaced with TPA, which is more safer and more effective in some studies. So most of this is secondary intraventricular hematoma, secondary to intracerebral hematoma. And we are still using urokinase only because of the availability. TPA is not available as 1 milligram, 2 milligrams like that. So that's why we are using urokinase. I think results are okay. Next, please. We try to clear the intraventricular blood as fast as possible. But sometimes this, you have to give 5,000 units every day for 3 days, and there's a chance of infection, cerebral ventriculitis. Cerebellar hematomas is a good subject. Actually, hematoma more than 3 centimeters on neurological deterioration, just as I told you earlier. Almost the brainstem compression and hydrocephalus ventricular compression. No surgical evaluation of brainstem hematoma. If pons or midbrain or medulla involved, don't touch. Sometimes there can be a stable course for 1 to 2 weeks under observation and treated later. One patient, when we discharged after 10 days, came back after 3 days, that is after nearly 2 weeks after the onset, and we had to operate. And he has a very good course. Next, please. So this is one condition where you have to follow for a longer time. The edema may, as I was saying in the initial few slides, edema may starts in 3 to 4 days after the onset and may go on up to 2 weeks also. So intraventricular hemorrhage and hydrocephalus. I think all of us know secondary intraventricular hemorrhage occurs in 40% of ICH patients. Primary is secondary is due to the rupture of either choroidal vessels or choroid plexus or subarachnoid small bleeds, which is more safer, benign. The amount of intraventricular blood, time for clearance, and development of hydrocephalus are independent risk factors for poor outcome. EVD placement is the treatment choice through which you can inject the thrombolytic drugs. Carries 50% mortality and serious disability in the survivors. Next, please. This is one of the predictors of mortality. Once intraventricular blood is there, the stitch trial, and they have also shown that they have a very bad prognosis. So this is about the stroke surgery. So I would like to say a few words on carotid endarterectomy and my experience here from our center. Next, please. The endarterectomy versus carotid artery stenting. This, so many trials have, this is mostly in the 90s. NACIT trial, ECS, European surgery carotid trial, carotid ECST, it should be ECST, carotid surgery trial. CREST trial has compared the stenting and endarterectomy. It was clearly shown superiority of endarterectomy over stenting. Nearly 15%, only the CREST trial has not so surely shown, but later studies also have shown the superiority of surgery of carotid endarterectomy. Nearly 15% of acute ischemic stroke are secondary to carotid stenosis in the cases that we see. So we screen with the carotid Doppler or MR angiogram or CT angiogram. You find stenotic segments, but only very few of them are responsible for the acute ischemic stroke. The indication for carotid surgery, endarterectomy, are within 2 to 4 weeks of non-disabling stroke. They should not have 0 power. There can be at least 3 or above power, so the patient will have a useful life after surgery. And this is to prevent the next stroke. Recurrent EIS, and 70 to 99% of stenosis, mostly involving carotid bulb or proximal ICL. So what about 50 to 70%? So that is a very delicate indication where you have to decide. And one more thing is about this 2 to 4 weeks. One book has mentioned that up to 6 months also they have taken up cases of non-disabling stroke for carotid endarterectomy of the ipsilateral side. Next, please. Now, these are very important from our practice. A severe hypertension is a contraindication. Contralateral significant stenosis is again contraindication. Disease distal vasculature. You open up the carotid vessel, but distal vessels are not good. That's also not good. High carotid bifurcation, where it cannot be approached properly, more than 75 years of age. Though this 75 years is not clearly mentioned, but one book has mentioned that octogenarians have not been studied properly with this surgery. So the complications are local complications like hematoma, which will resolve infection, hoarseness of voice due to vocal cord paralysis, stroke in 2% cases, and death due to stroke or MI in 1%, and carotid restenosis after surgery. So I have followed some of the cases of carotid endarterectomy where we have done surgery. Afterwards, sometime maybe 3 years, 4 years down the line, they have again 30 to 40% stenosis, but may not be very significant. And I believe there is one more talk on carotid stenosis management in the last part of today's program. The next, please. So I'll only conclude with my experience. At our center, we have seen about 10 cases in the past 4 years. Of course, this year we have not operated anything because of the COVID situation. Operated at our center, 9 cases. Complications, one was vocal cord paralysis with hoarseness, improved in 1 week. One case had a hematoma, a surgical site which is associated with pain, and improved in 5 days. So these are only transient one. But the 10th case, next please. Next please. Next case was operated outside.
It's not moving. I'm trying.
Okay. This case came to us from outside. It had a very stormy course. 67-year-old male patient with recurrent TIAs and diabetes, hypertension, and coronary disease. He was operated, the endarterectomy was done, and after 7th day, he came to us because of focal seizures. He developed focal seizures, which gradually became generalized hypertension, ventilated, gradually recovered, but with dense hemiplegia, MRS5. Diagnosis carotid hyperperfusion syndrome. A few words on this hyperperfusion syndrome. Next slide, please. This is the long segment of 70 to 80% of stenosis involving distal CCA and proximal ICA and carotid bulb. On the opposite side also, actually it's not seen in this picture very clearly. There was some stenosis on the opposite side. Next, please. He was readmitted within 1 month with LRTI and died. The contraindication for endarterectomy in that case for uncontrolled hypertension and contralateral carotid stenosis. This case I presented, I think, that time in 2 or 3 fora. So carotid hyperperfusion syndrome is one of the dreaded complications of carotid endarterectomy. It is defined as increase in the cerebral blood flow by over 100% above the baseline. New onset focal neurological deficit corresponding to the hyperperfusion area, and also seizures. So all the 3 were present in this patient. The increase in, generally after endarterectomy, the increase in the cerebral blood flow starts 3 to 4 days after the endarterectomy and persists for nearly 20 to 25 days. So, and this patient came to us, as we remember now, on 7th day. Prognosis of hyperperfusion syndrome is poor, with 30 to 60% mortality and 80% survival having severe disability. Next, please. This was the large acute infarct involving left frontal, parietal, and temporal in the DW imaging. Next, please. This is the ASL, arterial spin labeling, which is showing the perfused area. The red one is the increased perfusion, blue is the lower perfusion. So there is increased perfusion, a lot of area getting hyperperfused, that is giving rise to seizures. So coming back to the carotid endarterectomy, intracranial disease is more common in our country. So we don't see so many significant internal carotid, cervical internal carotid occlusions. And many of them have got some other complication. So we have to select the case. So endarterectomy in selected cases is useful in preventing subsequent stroke recurrence. And carotid artery stenting may be useful temporarily when there are comorbidities. For example, there's a CABG, we want to take up a severe coronary artery disease. But this CAS, artery stenting, is a temporary procedure. Recurrent stroke in a stentor is not uncommon. I had myself see one cardiologist had done stenting for the carotid artery, and after 10 years, he has developed a big stroke. Asymptomatic patients of carotid artery stenosis need follow-up. Even if it is 70%, 80% also, don't meddle with that, and medical treatment alone. So, next. Oh, thank you very much for the patient hearing.
One more slide is there. Thank you, Radhakrishna.
Oh, also,
Thank you
thank
very
you.
much. Yeah, the AP Neurocon has awarded you the certificate of appreciation for for your contribution to AP Neuroscientists Association, and you have delivered the Muralidhar Oration for the year 2020 on the role of surgery in stroke, virtually held at Rajamahendravaram. And over to my co-chair for remarks and concluding the session. Dr. Lakshman is there?
Okay.
Rajesh?
Thank you, madam. Probably he did not join, madam.
Okay, fine.